control. Dr. Rosenthal is also the driving force behind the International Nosocomial Infection Control Consortium Foundation, where he holds the role of founder and chief scientific officer. Please welcome Dr. Rosenthal.
Good afternoon. I appreciate the invitation of the WoCOVA organizers, and thank you for attending this session. I will discuss with you these 7 steps. I will try to finish in 20 minutes. The first one is when we started 25 years ago in Argentina, measuring the rates and consequences of HAIs plus reduction. Then I was invited to go to other countries to evaluate the situation. Then when we saw the situation, we developed an online platform. Then we published the data we collected collectively, and then we implemented a program of a basic bundle, like the one published by Peter Knobos in 2006. Then, when we noticed something was missing, we conducted studies in low-income countries to identify what was wrong there, besides the obvious. And then we implemented a more comprehensive bundle with more components. This was published 25 years ago, approximately. Data of Argentina, the rate of BSI was 10 times above US. The extra length of stay was around 15 extra days, and the mortality was approximately 3 times compared with the patients without HAI. Also, we matched patients 142 with BSI, 142 without BSI by the same age, gender, severity score, underlying diseases, ICU, hospital, and period, and then we estimated that the extra cost was $5,000 per patient in Argentina. Meanwhile, in US, instead of 5,000, it's 36,000, just to compare. We also improved the hygiene from around 20% to around 70%, and when we applied the basic bundle, we could reduce the rate of BSI, but not as low as the rate we saw at that time in US. At that time in US, the rate was 4 BSIs per 1,000 in the 90s, but we reduced the rate to around 8. Step 2, I was invited to go to different places, and I took some pictures. We found crowded facilities with lack of distance, people sharing the bed, people so close and without semi-recombinant position, with the hand of one patient on the bed of the other patient. They are not even beds. This ICU has 42 beds, no one sink. I took this picture in April 2002, before CDC published the recommendation of hand hygiene with alcohol and rub, meaning that if they didn't have sinks, they didn't have also hand hygiene, they couldn't wash their hands. Then I took this picture in Latin America, sinks with no antiseptic soap, no paper towels, incorrect hand hygiene technique. I took this picture in Asia, in some country I will not share, with cotton balls already impregnated with some antiseptic and non-antiseptic in these metallic containers. You see here multi-dose vials with inserted needles, of course, everything contaminated, or one-use vials to reuse. Also, I found this semi-rigid container with administration set and three-bottle cord for flashing. They take from there and flash with approximately 10 to 15 steps. Then I found a couple of options of open IV fluid systems. They are basically 3 types: glass, semi-rigid containers, and burettes. All them open systems because they need to be vented. Also, this kind of insertion without maximal barriers. I took these pictures also in 2002. This was taken in Eastern Europe. A patient with an internal jugular without any kind of dressing, and also peripheral lines without good dressing, also three-bottle box. And then we developed an online platform. People access this platform, clicking on the link, using username and password, and they are in an environment which is exactly their hospital. Nobody can see this, it's encrypted data. This is the aspect of the platform with 27 models. The first models are for surveillance of HAIs and consequences, then for monitoring compliance with hand hygiene and bundles, then quality of healthcare. There are 27 models. The model number 1 is for surveillance of HAIs, of course, CLAPS is included, in adult and pediatric ICUs. The number 2, neonatal ICUs. Number 3, general ward, and then surgical site infections, and so on. This is the model number 1 with 5 tabs. The tab number 1 with the data of admission, which is the classic date of admission, gender, age, and so on. The tab number 2, the use of devices with a drop-down menu. For vascular catheters, we have between 25 to 30 options. I don't remember exactly the number because we updated this recently. And then one tab for the culture. In the tab of the basic devices, we collect the date of insertion and the date of removal of each device. Then in the tab number 3, the culture, the date of the culture, the type of the culture, the microorganisms, and the bacterial resistance to 50 different drugs. Then the tab number 4 is the HAIs, following the CDC and HSN criteria. Each time CDC updates the criteria, we update online. And the tab number 5, the last one, they upload the date of discharge and the condition, which are 2 options, dead or alive. And then in this way, we calculate the extra length of stay and the attributable mortality. They request the report on this platform, and they see the report in exactly 2 seconds with more than 70 tables and charts with proportion of HAIs per 1,000 line days, of course, CLABSI, pneumonia per 1,000 days, and so on, and also benchmark comparing the rate of this particular hospital, that is its environment, compared with CDC, compared with pool data of INI, and with data from Europe, Middle East, Latin America, and Asia. Also, with the microorganism profile and tables with the bacterial resistance per site. Also tables with the length of stay without HAI and with CLABSI or with VAP or with UTI or with more than 1 HAI. Another table showing the mortality, again with and without infection. Another table with the cost with and without infection. Step number 4, we started publishing our data per country from Argentina, Colombia, Mexico, India, Turkey, Brazil, Peru, Morocco, Cuba, Philippines, Poland, Salvador, China, Egypt, Lebanon, Turkey again, India again, Saudi Arabia, Kuwait, Costa Rica, Malaysia, Mongolia, Ecuador, Venezuela, Vietnam, and more. Also, we publish pool data. Thank you. We started publishing pool data in 2006, the first time in Annals of Internal Medicine with data of 8 countries. Then, when I was at IPIC meeting, Elaine Garson, the chief editor of American Journal of Infection Control, approached me and asked me, Victor, why are you publishing Annals instead of Asian? And I said, because of the impact factor. And she said, Victor, we are publishing CDC and HSN data, please switch to our journal. We accepted, and we started publishing there. This is the last one, published this year, this January, with data 45 countries. We published 9 studies, the first one in Annals, and all the other 8 in American Journal of Infection Control. We started with 18 countries and then 45 countries. The lowest number of patients we published is 200,000 since we are in American Journal of Infection Control. This is the last CDC report showing the rate of CLABSI per 1,009 days, 0.8. Our first study in 2006 showed a rate 20 times higher, then 9, then 8, then 7, and then stable in 5, including pandemic period. We also analyzed the data of what we call PLABSI. I know that there are many names. We call PLABSI, we like this way. Peripheral line as the BSI. We conducted this study in 727 ICUs, in 268 hospitals, 141 cities, 42 countries of Asia, Africa, Latin America, Middle East, and Eastern Europe. We also published the bacterial resistance. We compare our bacterial resistance with CDC as a benchmark, and as you see, MRSA is similar, but the resistance of Klebsiella, E. coli, Enterobacter, Pseudomonas, and Acinetobacter is 2 to 3 times higher, meaning that it's a big issue, the bacterial resistance outside. We also published the length of stay without HAI, currently is 6.5 days, with CLABSI 23 days, with CLABSI plus UTI 30 days, CLABSI plus pneumonia 30 days as well, 29, and CLABSI plus UTI plus VAP 35 days. Mortality without HAI 14%, with CLABSI 40%, CLABSI plus UTI 42%, CLABSI plus VAP 43%, and CLABSI plus VAP and UTI 47%. Step 5. We implemented a program of hand hygiene compliance and a bundle with few components following Peter Pronovost and IHI from US. We applied outside and we implemented this and using the same platform. Yes, they access the platform, they collect the data, they create the reports, and they upload the data like this, date of the opportunity of hand hygiene, the moment before and after, the 5 moments of WHO, the gender, hand hygiene, the technique, the product, and the towel, if they use towel. If they use water, of course. If not, no towel necessary. And they create the report in 2 seconds, and they see the compliance per opportunity, per month, per healthcare worker, and per gender. This per gender is useful to compare men and women and let them to compete to improve classic behavior, human behavior. We conducted a study during 13 years. We published this in ICHI in 19 low resources countries. We collected data of 150,000 hand hygiene opportunities. And we improved the hand hygiene with this strategy. And then we compare men against women, doctors against nurses, and neonatal ICU against adults. Show me your hand. Who wins? Who is the best? Women or men? Women? Men? Nurses? Doctors? Okay. Multiple logistic regressions, women are better than men. Nurses are better than doctors. Neonatal ICU better than adult ICU. Obviously. But now we have proofs. This is evidence-based. You can say women are better than men, evidence-based. And nurses better than doctors, evidence-based. We cannot find this. We cannot argue. Okay, this is what we developed called INIC multidimensional approach, or IMA. 6 components. Guidelines could be 5 components, 11 components, whatever. Guidelines. Then educational training, following our colleague, choosing a good one. Surveillance, using our platform to find the rate of infection, plus the consequences. Monitoring compliance with everything, and then feedback. The feedback is important to let them know what is happening, benchmark and so on, and performance feedback. We use the same strategy, the same platform. We collect the compliance with everything, maximal barriers, everything is there. We don't have time to read because I thought I had 40 minutes, but I have 20. Sorry for that. And then they create the chart showing the compliance with each one of these components. And then we publish the data from Argentina, from Mexico, India, Turkey, Colombia, Saudi Arabia, and again from Argentina, later with another strategy. And also we pull data from adult ICUs, pediatric ICUs, and neonatal ICUs, and we reduce the rate of lapse. Yes, we did, but not as much as we wish. We started with very high rates, sometimes 45 ESI per 1,000, sometimes 15, sometimes 20, and we reduced to which number? 7, 6, 8, but not to 1 or 2, because we applied the 5 components, and this is not enough worldwide. And the same here. Step 6. Then we started analyzing what happened outside US, and we analyzed several things. One of them was the impact of open and closed system. There are a couple of models of open system, semi-rigid, glass, urettes, as you saw before. And we compare the open system with the closed system, which is a collapsible bag. And we published the data from Italy, where it was at Ospedale Sacco from 2003 to 2006, Argentina, Mexico, and Brazil. And at Ospedale Sacco Hospital, we reduced the rate from 8 to 3, in Argentina 6 to 2, in Mexico 16 to 2 to 3, and in Brazil 6 to 3. And then we conducted the meta-analysis with Dennis Mackey, the father of the dust infections, who is my mentor, and we found the same. And we found reduction in the rate of CLABSI and a significant reduction on mortality, switching from open to closed. Needleless connectors. When I conducted research about the use of these devices from the beginning of the time of INIC, I found that the use of a needleless connector was very low. They use thermostop cock in 88% of the opportunities, 88% against 12%. These are different kinds of needleless connectors. We conducted a randomized clinical trial in India, around 15 years ago, randomized clinical trial with a group using what we call the closed system arm and another called open system arm. The closed system arm was needleless connector plus pre-filled syringe for single use. And the open arm was ribotocog plus manual admixture, which usually has 10 steps. We compared these two arms. And what happened with the closed system arm, the rate was 2. With the open system arm in these randomized clinical trials was 6. Then we started analyzing what is killing people in ICUs. And we collected data of 300,000 patients from our database, all the patients that were available there. And the mortality, overall mortality was 15%, the mean age was 52, the number of patient days were 2.2 million patient days, and the mean length of stay was 7 days, and the mean dwell time of the central line was 5 days, and the number of CLABSI were 6,000, pneumonia 11,000, and UTI 4,000. And this is the multiple logistic regression analysis. We identified that per each 1 day of stay increased the mortality 1%. Female gender, unfortunately, increased the mortality. We then conducted bioregion to identify why it is happening, but I don't have time to present this today. The age increased the mortality 1% per year of age. CL days increased the mortality 2% per day. And the most shocking was that the CLABSI, compared with PAP, with UTI, again, in a multiple logistic regression, finding independent variables, was the variable with the biggest contribution to the mortality. That's why this is our target, among others, but one of the main targets. We conducted another study with the same setting to identify risk factors for BSI, because if we reduce the BSI, we reduce the mortality. And this is the multiple logistic regression analysis. Length of stay increased the risk of CLABSI 3% per day of hospitalization. The presence of the central line increased the risk of BSI 4% per day. Internal jugular and femoral were those associated with the highest risk. Meanwhile, PIC was associated with the lowest risk. Tracheostomy increased the risk. Adult oncology is the ICU with the highest risk. Public hospitals more than private, teaching, and so on. And middle-income countries more than high-income countries, as expected. Step 7, now, the last one. We just published this like 1 month ago. We applied another bundle with more components because the 5 were good but not enough. The 11 components are the same of Prologos IHI plus more. Hygiene, maximal barrier, clotting skin antisepsis, avoiding femoral, reduce central days, remove as possible. Proper insertion site dressing, that you saw pictures, no dressing at all sometimes. Reduce length of stay. I was invited to speak in Japan in 2003, and they invited me to speak because they told me, Victor, we need to reduce the HAI rates because now the system is changing here, and we used to have the patient during 39 days in average, now we need to discharge as soon as possible, and this is just why we include this here, because of them and other people, in other hospitals, in other countries. Bath with chlorhexidine, use needless connectors, use closed IV system, and single-use flash. This was our new bundle. We included 316 ICUs in 100 cities, 30 countries, 283,000 patients, 1.8 million patient days, 60% were men, mean age 52, length of stay 6.4, 3,000 BSIs, and more data. I don't have time to read. Most of them were hospitalized in medical surgical ICUs. And regarding facility ownership, 42% were in private, 30% teaching, 23% public. And hospitals of 5 countries were in high-income countries, 15 in upper middle, and 10 in lower middle. You have the baseline rate per country and per continent. Speaking about continents, the global pool baseline rate was 12 in Latin America, 12 in Asia, 13 in Middle East, and 8 in Europe. And you have per country as well. And this is the data per period baseline compared with intervention, no time to read. And the number of patient days, as you see, many thousands. And we reduced the rate at the beginning was 15, after 1 month, 8, 1 month after 5, 4 months 4 to 16, 4, and with a follow-up of almost 3 years, 2 years and a half, 2. Very close to CDC, very close. Instead of 1, 2. Instead of 7, 2, compared with our previous data and benchmark. And we also reduced the mortality. And this is a chart showing the rates and conclusions. This surveillance and prevention program we implemented in Argentina was a good example for us to promote this and to disseminate this, to spread this. And during my visits, I found some issues there, and I developed this online platform that we provide for free for everybody who is willing to use. And this was useful to demonstrate the situation. And this basic program we implemented at the beginning was useful to reduce the rates from 15 to 4, to 5, to 7. And when we conduct research, we identify another issues. And when we identify significant risk factors, we modify them. And when we implemented the new bundle, we reduced the rates to a perfect, almost perfect rate, and everybody is invited to join us. Thank you so much. This is my debate.
I think we have a couple of minutes for questions. Well, while we're waiting to see if anyone has a question, do we have questions? Yeah, okay. Well, I have a question for Dr. Rosenthal. The advanced bundle to prevent collapses, is that available on the website, on your consortium website?
The bundle is not available now. It is available on the paper we published,
Okay.
but we can add it on our webpage. I manage the webpage. We can do that. We can do that. Yes, it's not now, but the paper is there.
Okay.
And everybody who wishes to receive the paper, send me one email, and I will send you the paper.
Great, thank you.
Does anybody else have a question? Yep, I think someone's coming up.
Hello, my name is Ifta. I'm a doctor from Australia. This question is for Massimo.